I was always achy and tired and cold, and my brain just didn't work as fast. There were so many things that I recognized later that were thyroid symptoms, and I recognized them because they went away. And it was like, oh, I feel like a different human being.
Hello, everyone. This is Dr. Nita Lwanga here. I have my friend, Dr. Dana Gibbs. She's a board-certified otolaryngologist and thyroid specialist. She focuses on integrative approaches to complex thyroid and hormonal imbalances. As a founder of consultants in Metabolism, she treats conditions such as Graves' disease, Hashimoto's disease, and other metabolic disorders. Her approach balances conventional medicine with a holistic approach. She addresses both thyroid disorders and broader hormonal imbalances. I'm so excited to have her on the show because I serve so many patients with thyroid disorders, hormonal disorders, and oftentimes I feel like I'm doing my patients a disservice because some of the approaches in conventional medicine are a little bit limited. And I'm also not an endocrinologist, so I love my endocrinology specialists or my friends as well. They're very rare, but Dr. Gibbs is going to give us a little bit more information about thyroid disorders. Welcome, Dr. Gibbs.
Hi, thank you so much for having me here. I am really excited to speak to you and to your audience. This is going to be great.
I am so curious. How did you go from being an otolaryngologist, and of course, I'm having trouble pronouncing that. I think I need it this morning, to specializing in thyroid disorders? That is an unusual path. I suspect you're probably one of the rare, if not the only person who's taken that path. But I'm so curious, how did you come to this specialty?
Sure. Definitely not the only one because some of my mentors are actually also otolaryngologists. And I think it's just much easier to say ENT specialist. So anyway, so yeah, I started out in medical school. It was funny because I'd wanted to be a doctor since I was really little. Really like 8, 9, 10 years old. I really wanted to be a heart surgeon or something like that. And as I got closer and closer, I almost didn't go to med school at all because I had started being really tired all the time, really tired. And by the time I was done with college, I was like, oh, there's no way I can do this. And I said, I'll just go work in a research lab. It'll be fine, blah, blah. But I got into the research lab and I was like, oh no, this is not enough. I got to be the doctor. Yeah, this is not enough. So I did the med school and oh my God, yeah, I was so tired all through med school, all through residency. I picked ENT because it was surgery, but it was also more outpatient surgery and more go home at 5 every day and not spend all your whole life in the hospital kind of surgery. So I got really lucky when I picked ENT because it's just, there's so much there. It's so fascinating. And because thyroid surgery is part of ENT, I was already seeing a lot of thyroid patients in my practice when I first went to a conference and I sat in a lecture and the guy was like, oh, you don't have to have low TSH to have thyroid problems. Boom, light bulb moment for me. And he put up a list of symptoms, and we can talk about what those symptoms are in a minute. But he put this list of symptoms up there, and I was like, oh my goodness, I have thyroid problems. I have this. I have what he's talking about. And so I went and talked to him afterwards, and he said, yeah, if you will take this particular medicine, you'll feel better. And I went to my doc and I said, please, can I try this? And I did. And it was like this miracle for me because I'd had all these symptoms. I was so cold when I would lay down in my bed to go to sleep. My hands and my feet were so cold that I would lay there for an hour, not able to fall asleep because it was just painful. I needed what felt like twice as much sleep as everybody else. I was always achy and tired and cold, and my brain just didn't work as fast. There were so many things that I recognized later that were thyroid symptoms, and I recognized them because they went away. And it was like, oh, I feel like a different human being. This was already, I was out in practice. I'd been out in practice for 3, 4 years, maybe even 5. I don't remember exactly. But once I had that picture in my mind, I could not unsee it. I was like, oh my gosh, if a patient has this, and they're coming to me for a lump in their thyroid, or they're coming to me because they have sinus infections all the time or throat infections all the time, and nobody can explain why they keep getting sick, I should check their thyroid in the way that that guy talked about and take care of them. And it didn't feel that weird to me to do that because I was already taking care of them, doing their sonograms, doing their thyroid surgery. And they would come back to me after their thyroid surgery and they're like, Doc, I gained 20 pounds. I gained 40 pounds. I feel like shit. And their TSH was fine. And I'm like, I know this is thyroid because it wasn't there before the surgery. And it became really painfully obvious to me that the way we test for problems with thyroid is not adequate. And so when I finally found the mentor that I have now who explained to me this different way to do thyroid labs, it was like, oh, this makes so much sense. And I would say, look, Miss Patient, you have these sinus problems. I can't tell you anything else that's wrong with it, but you also have these thyroid symptoms. So let's try you on some thyroid medicine. And 6 months later, they'd come back and I'd be like, when are we going to do your sinus surgery? And they're like, oh, no, I don't need sinus surgery. I'm all fine. I just need more of that thyroid medicine. I'm like, whoa, another light bulb moment. It's okay. There's really something to this. And time went on and more of my patients who were on thyroid medicine, they became more and bigger part of my practice because word spreads. When you treat something that other people aren't doing and it's working, then the word spreads. But those people started having menopause and they'd be like, oh, can't you please do my menopause hormones? And I'm like, no, I can't do that. I'm an ENT. But as I got ready to retire from doing surgery, I was like, why don't I do that? Why don't I go and get the courses and the books and the knowledge and learn how to do that? And what I realized was that they're related. The thyroid and the menopause hormones and the cortisol and the insulin, they're all related. They all affect each other. And if you just treat one and you don't address the others, the person is not going to get all the way. They're not going to feel like themselves. And so that's a long-winded way of getting you where I'm at now. But there are other docs. There's a fellow in New York State that does this, and there's a guy in Kentucky who's my mentor. And we're working on teaching other folks how to know how to do what we do and how to know what we know. If you're a doc and you're listening to this and you want to learn it, come find me.
Wow, this is so fascinating and so intriguing, and it makes sense because I'm sure I'm an internist, and even as a non-internist, like as a surgeon, the fact that you're telling me a lot of patients would come with symptoms we can't explain, I find that a lot as well. I have patients who have fatigue and we do all the blood work and it's send you to counseling. Let me try to support you. But it's like, that's not the solution. That's not fixing their problem. So it makes sense. Like when you state it, of course, all the hormones affect each other. It's certain things as in silos. You're like, this is the thyroid path. This is the adrenal fatigue path. And at the end of the day, it is connected. So I'm very curious and very fascinated. And I have more questions than I plan to ask you. I think my next question is going to be going back to the thyroid. What are some of the symptoms that somebody with thyroid issues might have despite having a normal TSH, T3, T4?
Sure. When I look at a patient, when they first walk in and sit down and we're saying, hi, hello, how are you? The first thing I notice is how thin is their hair on top of their head. If I can look through and see their scalp and their scalp isn't covered by their hair up in the top, I'm immediately suspicious. Immediately. The next one is if their eyebrows have fallen out on the outer corners. That's another thing. I'm immediately suspicious. And I always ask them because ladies, it's not so common now, but ladies used to pluck their eyebrows and then they wouldn't grow back. And that's not the same. But if you didn't pluck them out and they just disappeared, that's another thing. I'm immediately very suspicious. And then there's a few other things that are really common in low thyroid. And one of them is GI problems, particularly constipation, but it can be like IBS type symptoms as well. Even GERD, even reflux, where acid will end up back up in your throat and make you hoarse. So hoarseness is another one. When people come in, their voice is just, it's not the only thing that causes that, of course, but it's something. And then this being cold all the time. I have people come in, they're like, oh, I'm just cold natured. Yeah, you've been cold your whole life. That's what I was. I had been cold my whole life. Go into the movie theater in August wearing a heavy coat and everybody else is, it's so hot. And I'm like, nope, I'm freezing. That's another one. And then sleeping too long. People are like, I'm tired. And you say, oh, well, how long do you sleep at night? And they're like, oh, 5, 6 hours. I'm like, oh, come on. Really? You need at least 7. But if they say, oh, no, I sleep 9 hours a night, and I still need a nap in the afternoon. That's another big yellow, at least a yellow flag, if not a red one. And then I'm going to put weight gain there's other stuff, menstrual irregularities, a lot of menstrual problems, infertility, miscarriages, one after the other. Those are very common. Lack of stamina, lack of being able to go to the gym and build muscle. That's another thing, because you have to have adequate thyroid in order to be able to build muscle. I just thought, oh, I'm just thin. I'm just being physical. It's just not my thing. I didn't know that was a thing. I didn't know that was a thing until my 50s, when I actually started making myself go to the gym and realized, hey, I can actually have muscles. This is cool. So that's a lot of different things. But the last one, and it's interesting because a lot of the people that come to me are like, Doc, I can't lose weight. And yes, low thyroid lowers your metabolic set point. So it does make it harder to lose weight. But it's not the only thing, because low thyroid and insulin resistance are really tightly wrapped together. And insulin resistance is so common anyway. What is it? 50% of America has insulin resistance. And I think that percentage is much higher in people who also have low thyroid. But just fixing thyroid for a lot of people who really have big problems with their weight is only about 10% of the problem. They really have to go in and address their insulin resistance, or they're not going to lose the weight they want to lose.
Wow, that is so fascinating, and it absolutely makes sense. And for individuals, say there's somebody out there who's listening to us and they've had all the thyroid tests done and they're saying, hey, these symptoms sound familiar, and they want to reach out to you. I'm just going to pop it right in right now, because I'm sure people are like, let me start Googling Dr. Gibbs.
Sure. So
your website and where you work, so that people, if they're listening, this is not live though, but if people multitask, so they may as well start Googling you right now.
Yeah. So my website is danagibbsmd.com. That's pretty simple. I also have a podcast. The podcast is called Beyond the Thyroid, and it's on Spotify and Apple Podcasts and all the places. It's pretty new. I think I have 20 episodes so far, but I'm really trying to start at the beginning and go one topic at a time and go deep dive into each one. And hopefully that's super helpful for people. But yeah, that's how you can find me.
Okay, awesome. And we'll make sure that we put your website and your podcast in the notes below so that people can find you. So right now, if they're listening, they should go ahead and go to your website and download your podcast. So going back to the thyroid disorders. So say you diagnose an atypical thyroid disorder that most doctors already missed. And now people are going to get on treatments. Would the treatments that you offer be treatments that are offered conventionally? Is it going to be a prescription, or does it depend on what you find? And would they be able to find prescriptions, say, through their pharmacy?
So it can depend. So if somebody is in my state and I can be their physician, then I do use prescription medicine if it looks like that's what they need. But even before that, I will have them optimize some other aspects of their health using supplements and or just nutrition in general, because there are several minerals that are essential for thyroid function that some people can be deficient in. And those are zinc and magnesium and iodine and selenium. And with those last two especially, you have to be super careful, because it's very easy to get too much of those as well as not enough. And they can be toxic, and they can actually trigger thyroid autoimmune disease if you take too much of either one of them. And so it's really important to get that right for people. Another thing that I will have people do is, and here's something a little bit ironic, because so many people with low thyroid problems have started having hair loss. A lot of them will be on supplements that are supposed to make your hair grow. And the problem with those supplements that make your hair grow is that they can mess up your thyroid test to the point where you can't tell that they're abnormal, because it makes them look better than they really are. And so that's the next thing I do, is I say, look, you must stop taking, and it's biotin. Biotin is the big thing. It really messes up thyroid tests. And so if you're on a supplement with biotin, you have to be off of that for about 3 days before you go and get your thyroid looked. So if it looks like somebody has the wrong balance of thyroid hormone, or if they need to take thyroid hormone and they're not, I tend to use a lot of prescription liothyronine. And liothyronine is T3. It's the active form of thyroid hormone. And we can talk more about why that is, that I use that particular one. The other thing that I sometimes use is the combination, the products that are natural products. They're an animal-based product called natural desiccated thyroid. I will use that for some people because it has all of the thyroid hormones and metabolites in it because it came from an animal's thyroid gland. And for some people, they just do way, way better. And it's readily available. It is a prescription, but it is something that more people are familiar with than are the synthetic liothyronine, which is the synthetic T3.
Wow, I'm glad you mentioned that because I've had patients ask me about synthetic T3 and the desiccated thyroid medication. And the thing is, with conventional medicine, like if you're just a general internist, I have not had any experience with any of those medications. Yes, I'm so glad that you're using them because it definitely validates what, though, I mean, with a grain of salt, I'm not sure where my patients are getting this information. I hope they're getting it from your podcast.
Probably not, but they should.
I have not been comfortable prescribing them because, of course, my knowledge is limited. So I'm very happy you're mentioning this, and I'm going to have to listen to your podcast. And perhaps whenever you launch, hopefully you're going to launch a course maybe one of these days.
Yeah, no, I absolutely am. So here's the deal. So T3 or synthetic liothyronine and these natural medicines have been around for a really long time. And if you talk to endocrinologists, they will say, yes, we do see that there are some people who seem to need to be supplemented with T3, but T3 has a bad rep because it's very strong and it has a very short half-life. There's not a lot of big studies, big scientific studies from big institutions out there that explain, actually there's none, that explain a safe way to use it and a consistent way to use it and a way to follow it where you're not overdosing and you've controlled the symptoms. Because if you give it too quickly and too much, the patient will have symptoms of hyperthyroid, which means too much thyroid. And those are very uncomfortable and even dangerous. And so if you don't know what you're doing with those, you can really mess people up. But the system that I use has worked for me now for 20 years, and it worked well for my mentor for 25 years before that. So we're really confident that we can do this without causing and triggering a bunch of symptoms for people. And the endocrinologists are waiting for big data to tell them, okay, this is safe, this is the right way to do it. And I understand that because we were all taught, we all took this Hippocratic oath, first do no harm, right? If you don't know that what you're giving somebody, if you think it might harm them, then of course you're hesitant, and if the guidelines don't tell you what to do, and all of us were taught those guidelines, there's nothing wrong with the guidelines. They just don't go far enough.
I like the fact that you said that. You're right. There's nothing wrong with the guidelines that just don't go far enough. And I think that's any area of medicine. I've not been in medicine that long, but I feel like the years I've been in medicine, even the definition of hypertension has changed 5 times. I'm like, now
yes,
hypertension stage 1, and then depending, now you have CKD, this is your target. Now you have proteinuria, this is your target, your sprint candidate. And it's like a lot. And I think as we get more information, we keep changing, yes, but that's extremely important. Like the guidelines, there's nothing wrong with the guidelines. I'm going to repeat that in your own words. There's nothing wrong with the guidelines. They just don't go far enough. I really like that.
Yeah. So go ahead and ask me another question because I just got tongue-tied.
I just wanted to quote that. That's like an amazing quote. I think you should repeat it because I really love that. But my next question. So the thyroid and weight. I want you to talk to us a little bit more about like how does a fast thyroid cause weight problems or slow thyroid cause weight problems? Do people's weight or does somebody's weight normalize as soon as you treat them for their thyroid disorder? Or do you usually suggest that they do something else to help them manage their weight despite having thyroid issues?
Sure. So absolutely. So what we talked about at the beginning, just very briefly, is that thyroid definitely is a big factor in weight gain and the inability to lose weight, but it is not the only factor. And what thyroid controls is the basal metabolic rate. So basal metabolic rate is the energy your body burns just to exist, just to breathe, just to maintain fluid balance, just for your very basic, most basic functions, to keep your brain churning around. And when you have inadequate thyroid, it will slow down your basal metabolic rate. And if you have too much thyroid, it will increase your basal metabolic rate. So we alluded a little bit to too much thyroid a little while ago. And so, yeah, if you have Graves' disease, and Graves' disease is one of the main hyperthyroid conditions, one of the things that happens is that you're anxious and you can have panic attacks because your brain is just going too fast. You can lose weight rapidly because your metabolic processes are just going too fast. You can have a high heart rate because your heart is just beating too fast. Your heart is being sped up by too much thyroid. Your blood pressure will be raised. And I just have to say that all of that sounds pretty good to somebody who's trying to lose weight. But the next step is coma and heart failure. And you don't want to go there. It's terrible. So this is something I'm finding in the world of non-physician, quote unquote, thyroid experts, is they really push the doses up and up. Yes, it can theoretically make you lose weight, but it makes it hard to build muscle. It causes you to lose your bone density, and it can cause you to have heart failure. So you really don't want to go there. But the opposite is also true. When your thyroid is low, your heart rate is slow, your body temperature is slow, your blood pressure, your pulse pressure is very wide. So your bottom number on your blood pressure can be as low as down in the 40s. It can be mine was 86/40 some days. It was bad. And nobody thought anything. They're, oh, your blood pressure's great. I'm like, no, it isn't. I pass out. Low thyroid just doesn't push your metabolism fast enough. But the other thing that it does is it pushes you towards insulin resistance. And insulin resistance is a condition where you have to have more insulin to handle the calories that you take in, specifically to handle the sugar and the carbs that you take in. And because you have more insulin, it turns off your ability to burn fat as energy. And so you just pack it on. And so when you take thyroid hormone to get your metabolic rate back up to the spot where it needs to be, you also have to manage the insulin resistance, or it's still keeping you from burning fat. It's still keeping you from using fat as your energy source. And without that, you never lose the weight. And so you must deal with that also in order to lose weight as a hypothyroid patient. It's not something you can ignore and just expect the weight to fall off. It isn't going to happen.
That is so interesting. So in theory, based on what you're saying, is it possible, or have you seen that if you have a patient that has hypothyroidism with coexisting diabetes or prediabetes, if you treat their thyroid disorder, their diabetes improves, or if they have prediabetes, it goes away?
It's not magic. They really have to change the way they're eating. And this is the thing with low thyroid, when you have low energy all the time, a lot of people have gotten into a habit of, I was doing it. I was drinking a whole pot of coffee a day. And I would put, 2-3 teaspoons of sugar in that coffee before I drink it. Because you don't burn fat for energy, you have to have sugar. And so you just get in this habit of sugar, carb. That habit doesn't automatically go away once you treat your thyroid. You got to fix it. You've got to get your insulin levels down. And the way you do that is by lowering the amount of carbs and sugar that you take in. And I always tell people, look, if you're drinking sodas at all, if you're drinking any drink that's sweet, whether it's juice, whether it's a protein shake, whether it's sweetened coffee, sweet iced tea, whatever it is, stop drinking sweetened beverages first. That's number one. It's the first thing you got to do. And so you work on one habit at a time. As you get more energy and as you feel better because your thyroid is now balanced and under control, then you have more energy to get up and go for a walk. You have more ability to sleep through the night and get 8 hours and actually get some benefit out of it instead of going to sleep freezing and then waking up drenched in sweat over and over again, which is what happens to people with thyroid problems. No, it's not magic. You can't just instantly expect your diabetes is gone. You've got to do the work.
Wow, that's fascinating. And even as you're mentioning those symptoms, I'm thinking of different patients that I've interacted with that technically have normal thyroid tests. And I'm like, ones that are usually like mysteries, that they have these unusual symptoms we can't explain. I'm like, wow, there's a lot of people I'm thinking about, but that's very true. The sugary beverages, I was smiling because for those of us that have a sweet tooth, that's an uphill battle. I've managed to semi overcome my sweet tooth, but then for those who are used to using coffee and sugar for energy, that could also be a sign of maybe a thyroid issue, perhaps. That somebody could present atypically that way.
It could certainly be that case. And, what you mentioned that it's a mystery. It's okay, somebody has a normal TSH, but they might still have a thyroid problem. So let's spend a second talking about that, because what we were all taught, all us doctors were taught, that your thyroid metabolism is very simple. Your thyroid makes hormone and your body uses it. And if there's not enough of it, your TSH will rise. And if there's plenty of it, your TSH will be in the normal range. And if there's too much of it, your TSH will be too low. And those things are true. But there are times when your TSH can be in the normal range and you can technically have, quote unquote, enough thyroid, but your body is not using it appropriately to activate your metabolism. And what I find in people is that there is a particular blood test that I like to use, and it's called reverse T. And you take a reverse T3, and your thyroid gland makes both of those substances. It makes total T3 and it makes reverse T3, and it puts them out into your system in about a 10-to-1 ratio. But your body needs more T3 than what comes out of your thyroid gland. And so your body has to activate T3 or activate the thyroid hormone T4 to make more T3. About 80% of what your body needs is made in the tissues, in your liver, in the body tissues after it gets into the cells. The T4 gets turned into T3, which then goes and does its job in the nucleus of the cell. So if you measure somebody's T3 and their reverse T3, and it comes out of the thyroid at about a 10-to-1 ratio. And if that ratio has gone down, if the ratio is 9-to-1 or 8-to-1, or God forbid, 2.5-to-1, I've seen that. I've seen it be as low as 2-to-1. If that ratio is going down after the stuff escapes your thyroid gland and gets out in your tissues, that means your body is not appropriately using thyroid hormone that it gets to activate your metabolism. And so I use that ratio to identify a patient who has, and when we were talking before the call started, you mentioned euthyroid 6 syndrome, or non-thyroidal illness is another name for that. And that's what that is. It's your body saying, oh my gosh, we have to conserve energy. We're going to inactivate the T3 instead of activate it. And so that's what happens, is that it comes out at a 10-to-1 ratio. If your body's inactivating it, then that ratio goes down, and you can measure that. And that's a really straightforward and easy way to do it. So what happens is, and this especially happens in people with insulin resistance, because here's the deal. When food used to be scarce, I mean, as recently as 100 years ago, food was even less than that if you count World War II. Food was really scarce, especially in the wintertime. And so our bodies evolved to conserve energy when food is scarce. But unfortunately, food is never scarce anymore. But some of our bodies still think food is scarce, and we do everything we have to conserve energy, even if that means our weight just goes up. And this reverse T3 goes higher and higher when our bodies think we need to conserve energy. When is that? It's when we're under stress. It's when we are dieting, calorie restricting, trying to starve ourselves. It's when we're injured. It's when we're sick. It's when, and here's the thing about stress. Stress is funny. Our bodies, what is that expression about a carpenter only has a hammer, so he tries to use a hammer for everything? Your body only has one response to stress, and that is cortisol. And whether the stress is, wow, my boss yelled at me today, or Jesus, I just got chased down an alley by a guy with a knife. Your body has one response, and that's to shoot your cortisol way, way up. And what does cortisol do? It raises your insulin resistance and it slows down your thyroid. That's what it does. It's all it knows how to do. I'm not saying cortisol is its own brain, but it's chemical signals that make that happen. But our lives are stressful and our bodies are not doing the same physical level of activity that our ancestors did in order to go out and find food.
Absolutely. I'm so happy that you mentioned that cortisol. I don't think I remember hearing that, or maybe I skipped that part of physiology. I was asleep. But cortisol is the only one. I was like, I either I didn't learn it or I missed it. But cortisol slows down the thyroid. That's fascinating, and that's also very scary. That's very scary.
Yeah. It does it in two different ways. The first way it does is by lowering your TSH without lowering the hormone, without raising the hormone levels. That's the first way it does. And then the second way is that it encourages your body to make more reverse T3. And so both of those make your thyroid labs look normal if all you check is the T4 and the TSH.
Oh dear. So I'm sure we're missing a lot of people. We're definitely missing a lot of people with thyroid issues, and especially people who are stressed out. Wow, this is so fascinating. Remind me, Dr. Gibbs, which state are you in?
I live in Texas.
Okay, I have to send some family members to you.
Oh my goodness. Okay, so there's one other thing that I didn't mention, and that is that there is actually a genetic SNP, or a single nucleotide polymorphism, that makes you inefficient at making T3 in your body tissues.
Oh,
and
wow.
I actually think maybe that's what I have, but there's really not you can't just go to the lab and order a test to see if you have that SNP. So I'm guessing that might be what I have because I've had it since I was tiny. And then there's one more thing that can trigger that abnormal conversion of T4, to reverse T3, and that is Hashimoto's disease. And we need to talk about Hashimoto's disease because it's super, super common. In the Americas, I think a statistic I saw was that 15% of American adults have the antibodies for Hashimoto's disease. And the problem with it is that Hashimoto's disease damages your thyroid gland. It's the most common cause of hypothyroidism. But even before it damages your thyroid gland to the point that you're frankly hypothyroid, it triggers reverse T3 to be made in preference to T3. And there's a lot of reasons why that happens, but just it's a common thing for people to have hypothyroidism that doesn't show up on the normal labs and Hashimoto's disease. And so if somebody has Hashimoto's antibodies, I'm immediately like, okay, we need to do this full lab set that I'm talking about and make sure that we support your metabolism and support your thyroid in a way that keeps that damage from getting worse and worse. Because that's the natural history of Hashimoto's, is that it just gets worse and worse.
Wow, like everything you're saying is triggering so many different interactions with different patients. Because I'm remembering patients with mystery labs, and I'm like, this is adding up. And unfortunately, I'm in Canada right now, so I'm gonna have to somehow tell my people if we have a shortage of endocrinologists, which is another challenge. But I'm like, if you're traveling, I probably
Here's an interesting one. This is probably going to be my next podcast episode that I record, is the interaction of vitamin D with thyroid. Because you live in the Great White North where people stay inside all winter and get no natural vitamin D conversion. And if you have dark skin, of course, that's worse. And so vitamin D deficiency is super, super common. super common. And one of the interesting things that I found out is that a lot of people who get put on levothyroxine because their TSH rises towards the late winter and spring when they have been out of the sun for the longest time. So your TSH will rise, your T3 will basically disappear. And so I wonder this to myself because I didn't see any studies that connected those dots. I wonder if seasonal affective disorder is actually a thyroid problem. And if all you have to do is add some more vitamin D to get rid of it, I would be like, oh, that's very interesting. But another thing that vitamin D does is it makes you, if you have low vitamin D, it makes you more susceptible to autoimmune diseases. The one that's the most studied is type 1 diabetes because there are big studies that have been done. If you live near the equator, how big is your chance of getting type 1 diabetes? Almost none. The farther away from the equator you go, the higher your chance of having type 1 diabetes. And I wondered to myself, is that because of vitamin D? Because the farther north you go, the more prevalent low vitamin D gets. And it just really makes me wonder. And what's the most common autoimmune disease? It's Hashimoto's disease. We just talked about it.
Oh, wow. That is so fascinating.
Mind-blowing. That has just come on my radar just in the last few weeks, and I'm blown away by that idea. Take vitamin D to prevent Hashimoto's disease. I was like, dang.
Are you connected to anybody that's doing research? Because I'm like, you have good questions.
I wish I was. I have a very small practice. I have very low numbers of patients. I live in Texas where we have plenty of sunshine. Maybe not this week, but most of the year we have plenty of sunshine. I would love to get the ear of somebody academic and start doing studies. And I think the first thing I'm going to do is just put together a case series of my own patients. But yeah, I really want to know the answers to these questions.
And they're fascinating and they make sense. And that's the thing with medicine. It's like the more we know, the more we realize how little we know and how many more questions we have. Like that's the beautiful and also stressful thing about medicine. But
it is so true.
I love your thought process and I love all the questions. And I still have more questions for you. But I think in order to respect your time, we're going to have to bring this episode to a close. But I'm going to have you back. I want to ask more about adrenal fatigue. You mentioned that you're working with women that have menopause. I have a ton of questions about that. So I would love to have you back if you're willing to come back.
Absolutely. I would love to.
Oh, thank you again so much for being on the show. And for everyone who's listening, thank you for listening. If you want to connect with Dr. Gibbs, we're going to make sure that we have all her social media sites and her podcast in the description notes below so that you can follow her. Thank you again for listening. Goodbye for now.